Good evening, Nachiket Mor. Right at the outset, our sincere thanks to you for accepting this invitation and participating in our 55th annual day.
It's a pleasure, sir.
Opportunity to introduce Nachiket Mor to the audience. I am sure many of you are very familiar with Nachiket Mor. Nachiket Mor is a trained economist. His work is principally focused on the design of national and regional health system. Nachiket is a visiting scientist at the Banyan Academy of Leadership in Mental Health and a senior research fellow at the Center for Information Technology and Public Policy at the IIIT Bangalore. He is also a member of the Health Insurance Advisory Committee of the Insurance Regulatory and Development Authority of India, IRDAI, and a commissioner on the Lancet Commission on Reimagining India's Health System. Thanks, Nachiket, again for accepting our invitation to address our member on this important topic, insights on improving healthcare access with quality. Thank you so much. Over to you, Nachiket.
Thank you very much, Mr. Anand Krishnan and the OPPI team for inviting me to speak to this August gathering. It's a real pleasure to be here. And thank you very much for taking the time out to listen to me. As has been already mentioned, health systems design is an area in which I have a keen interest, and I've been working in it for the last several years quite intensively. We already know, and I don't want to repeat this, because that India, and you represent a global federation, relative to many nations, including several that you come from, has a poor record of delivering healthcare access on the three dimensions that we normally look at when we look at health systems, which is health outcomes, financial protection, and responsiveness, both for the population as a whole, but also measured for the bottom income quintile in each state. It's also well understood that these results are on account of a consistent failure as a country, a large, relatively prosperous country compared to many of our neighbors, to use our limited resources in an efficient manner, and in our inability to provide access to high quality healthcare and services to our peoples. The question, of course, is, which is not well understood, is what are we going to do about it? And I'm not going to suggest to you that we have not made any progress. We have. Life expectancy in India at the dawn of our independence was 37 years. Today, it is more than double that number. That is a remarkable achievement. But relative to where the countries are, relative to where the potential of the country is, there is little ambiguity that India is a strong laggard in terms of health systems. What I want to engage you a little bit on is some of the ideas that we could ponder over as we think about where India might go as it attempts to build a health system that is truly worthy of its potential as a country and of its capabilities. One issue that is very clear in terms of financing for healthcare, which is kind of a key aspect of any healthcare challenge, is that no country has been able to build a truly high-class healthcare system without the finances for healthcare coming via its government for over 70 to 75% of total health expenditures. The fact that in India, across all our states, and we have about 30 states, it is between 30% to 50% against a requirement number of 75%, with the rest going for the most part directly from citizens to providers, remains a key impediment. And no matter what schemes we use to deliver or finance healthcare, state governments will have to find a way to increase their expenditures to the levels needed if the state is to have any hope of providing access to good healthcare to its residents. Unfortunately, here, there is little ambiguity. The global evidence is pretty strong and clear. Unfortunately, despite that clarity and despite that imperative, if you look at the review of finances that has just come out of the various state governments, it's called the State of State Finances, prepared by the Parliamentary Research Service, they continue to prioritize expenditures in sectors where I believe markets are actually perhaps better suited to take over, or the protection needed by vulnerable people is best given directly to them as cash instead of engaging with the underlying sectors. But because of this decision by the states, services like healthcare, for example, are unable to find the resources that are needed. To solve this issue, a continued dialogue with each state government will be needed, because I think we have to begin with the mental model. And it's possible that many of you, coming from the diverse countries that you're coming, and that you know so well, you may be in a good position as you engage individually with bureaucrats, with senior leaders, to communicate to them both the urgency of this issue, as well as what your own experiences and your own national experiences has been. On this issue, there isn't really that much of a choice. On the issues that I'm going to raise, subsequently, there are choices to be made. Countries have not universally gone in one direction or the other. I'm going to certainly suggest that the weight of the evidence suggests one direction for us in India, but one could argue, there could be some debate about, what would work for every state. Will the idea that I'm proposing, will that be the right answer for all the 30 states, or maybe only 20 of them, or maybe only 25 of them? So one issue is, how do we govern our health system? Because, there is certainly a concern that citizens are spending a lot of the money from their pocket directly for their healthcare. But let's for the moment assume that we are able to persuade our governments to come up with the money, and that citizens no longer have to spend that kind of money. But it still remains a valid question: how are we going to govern the health system that we have? In India, like many other developing countries, we have been very strongly wedded to what is known as a Semashko model of healthcare. This evolved in the Soviet Union in the 1920s under the guidance of Dr. Nikolai Alexandrovich Semashko. Post the breakup of the Soviet Union, all of the newly formed countries chose to walk away from this model, to the point that this particular model has become the preserve now largely of low-income countries and low and middle-income countries with poorly performing health systems. A key departure that most countries, and in fact, there is evidence that this has become almost a consensus on a global basis, but almost, there are still notable exceptions. Following the reforms in the UK health system under Mrs. Thatcher, most countries recognize that even if the health system was entirely government-owned, as in Turkey or in Thailand or Vietnam, if it is to operate in an efficient manner and to provide high-quality access to its entire population, it was not enough to just provide adequate government funding. There was also a need to bring what we call an internal markets discipline to bear on it by removing automatic budget-based funding of health departments and paying even public sector hospitals and clinics only on an outcome-related basis. In fact, in Thailand, early in the reform, several government hospitals that were either not seeing patients or not doing such a good job had to be shut down or reduced in capacity because of this. In fact, from its early start in the late 20th century in the UK, there is a belief, as I said earlier, that this is almost a consensus in the way forward to ensure that good outcomes are achieved from health systems. Now in India, while the very impressive capabilities built by the National Health Authority provide confidence that this is a pathway that India could reasonably follow, given our technology, given all of the other infrastructure that we have, This is a radical departure for India and will need a fair amount of internal debate before we go ahead in this direction. But as I said, there's almost an emerging consensus that if we don't do this, even if we pour a lot of money into the health system, we will not get the outcomes that we want. The second issue is who provides the service. Unlike in the case of financing, where I said earlier that there is little ambiguity that financing will have to come from the government or via the government, it is not clear, if you look at developing and developed countries, that government being a dominant provider is either necessary or sufficient. In fact, all systems, with perhaps the exception of Cuba, are all public-private mixed health systems, with the degree of importance varying from country to country. As you know, in the UK, while the government finances the whole health system, the primary care is provided almost entirely by the private sector, which is paid for by the government. In the secondary and tertiary care, you see a much more mixing of public and private providers. However, one thing is clear, that countries that have gone the route of what we call indemnity insurance, in which you have an insurance contract and then you go and shop around to providers to say, you know, I have a limit of $100,000, $200,000, $1 million, who will take care of me when I'm sick? That approach has not really worked out very well for many countries. If I look at, for example, United States in the context of Medicare and Medicaid, Japan, Taiwan, Germany, these countries have discovered that this approach, while appealing in the short run, is not giving us the kind of results that we want. Inflation levels have gone up. Health outcomes are not necessarily the ones. Japan, for example, the evidence is uses MRIs, CT scans at a level, I think there is 4 or 5 times higher per capita than the UK does, without necessarily the incremental benefit that we are seeing. And therefore, the importance of preserving or recreating, you know, what we would call the free unlimited care environment to a group of patients, in which when you're part of the health system, you're not waiving your contract at various people, but you're going smoothly from primary care to secondary care to tertiary care, is indeed a superior mechanism. But there is a need to ensure that there is a strong safeguard against denial of care. Because once as a patient, I have paid up my money, what is to stop the provider from saying that, you know, even if I'm very sick, from saying that you're not sick and therefore not providing me care? These models are starting to become a lot more successful and a lot more valid in terms of the direction in which countries are going. At the national level, you see countries like Thailand, where the government is a dominant provider going in this direction, and Israel, where private managed care has become much more prevalent and has been successfully implemented. At a sub-national level, while countries are still struggling with the national level solutions, within the US, several health systems, we've all heard of Kaiser Permanente already, but also now Geisinger, Intermountain, Providence, Henry Ford have moved in this direction. And this is something that we in India need to consider very strongly. If this model is to emerge, the regulation will have to permit the merger of private healthcare providers and hospitals with health insurance companies, and will have to allow them to conduct their operations using mutually exclusive relationships. You know, many of the pharmaceutical companies are interested in medicines that can cost a lot of money, or providing services that can be quite expensive. One direction to go, of course, is to control prices, is to make sure that those numbers are kept reasonable. But another direction, which I think is a more promising direction or equally promising direction, is to ensure that everybody is covered by some form of insurance, so that when they go to the hospital, the price issue does not any longer become a barrier for them to seek care. Even on the government front, you know, even as we wait for state governments to find more money and to increase their level of commitment to healthcare by 3 or 4 times, it is possible for them to use the umbrella capability of the National Health Authority and to offer a government design, what the Americans call the public option. And while this approach, a public option is a government designed insurance contract that anybody can buy if they wish to have a base minimum level of healthcare. Now, this approach, we know from global evidence, is unlikely on its own to lead to universal health coverage, but it will allow middle income residents to invest in their own financial protection. And we've seen some evidence of this in the Philippines and in Indonesia. Of course, state governments will need to take care that they rethink the current indemnity insurance approach that they have taken in their government insurance schemes. Otherwise, there's a real risk, as I mentioned earlier, that over a period of time, they will end up with a predicament similar to that of Medicare and Medicaid in the US, where even at close to 8% of GDP, the government is unable to protect more than 40% of its population. And even despite spending that money for only 40% of the population, is not able to ensure good health outcomes. And this, we believe, came because under Lyndon Johnson, the government decided to go in the direction of the Blue Cross Blue Shield was the dominant healthcare plans, and they were indemnity insurance. And the government decided to emulate that entire structure. And we believe that particular moment of decision, over a period of time has produced the outcome that we see today. And we believe at that moment for ourselves, and we need to take care that we don't end up where the US government has ended up. Also, finally, there is this other big issue which we need to confront, is that despite all of the discussions of government financing and insurance, sadly, out-of-pocket expenditure remains the dominant form of health expenditure for most Indians. As a result, we have both a very low level of financial protection. You hear the evidence is that somewhere between 6 to 7% of the population falls afresh below the poverty line because of healthcare expenditures. And since in India, with a population of 1,300 million, 6 to 7% of the population is a very large number of individuals, over 60, 70 million people. There's also evidence that about 15% of the population, an even larger number, has to forego care because they're not able to afford this care because of this out-of-pocket nature. So almost 20-21% either become extremely poor at the end of that episode or simply cannot afford the care. And then clearly, this is the reality that we have to confront, and we may have to confront for a while. In addition, what has happened is because of this environment, consumers and providers have gotten used to a free market approach towards healthcare, which has forced providers to remain at suboptimal equilibria with low total revenues. The Indian corporate sector is less than 4% of the total market, even though they charge high, sometimes usurious prices. So at an individual transaction level, you're seeing high prices, but because of this underlying model, the aggregate revenues actually are low, and the outcomes are not actually very good, even though there is a concern that there is an over-provision of care. And similarly, at the customer end, there is a certain habituation that I go wherever I want, I talk to whoever I want, I call up a specialist whenever I feel like it. And clearly, this free market habit is something that we will have to address. And countries like Taiwan, for example, that built a new health system, or Japan, built a new health design. But Japan is not so new, but certainly Taiwan is. They've discovered that this free market approach, without gatekeeping, without there being a steady primary care provider that is worrying about you from cradle to grave, you're not going to get good outcomes on a universal healthcare front. Clearly, urgent efforts need to be made to improve the value that customers derive from out-of-pocket expenditure while ensuring the providers act in their best interest and break this habit. The worry I have is that many of the developments on the e-pharmacy and the telemedicine fronts is headed in the wrong direction and actually is creating more fragmentation, more shopping by customers of doctors or primary care providers and of specialists. And some effort will need to be made to figure all this out. Finally, we will also have to follow global examples from countries and regions such as Alaska, Indonesia, South Africa, and Portugal to find ways to fully activate all the possible channels of outreach to consumers, including, like in Alaska, highly trained community health workers that provide comprehensive primary care, mental health, diabetes, hypertension to very remote communities. Pharmacies, something that you all deal with on a regular basis, which can address many chronic diseases. And other members of the household that can be trained to provide better healthcare to people. Schools that can act as important channels for ensuring that children get good healthcare. Clearly, using all of these mechanisms, new human resources, new technology to make this happen is going to be a key part of ensuring that even as we work to build our longer-term health systems, on a here and now basis, consumers are able to get better value from their out-of-pocket health expenditures. I will stop here and turn it over to the organizers to see if there are any questions. I can certainly go on for much longer, but I've given you a broad sense of where my thinking is. Thank you very much.
Thank you, Mr. Moore, for that wonderful session. I would here like to invite Mr. Ananthakrishnan back on screen to ask you a few questions. And here I'm also inviting and encouraging all our viewers to send us your questions using the Ask a Question button, which is on the left of your screens. Over to you, Mr. Ananthakrishnan.
Thanks, Kathy, and thanks, Nachiket, for bringing in, a very broad perspective on how state governments need to step up and how we need to engage with state governments a lot more to see what could be the best model of healthcare that can be, implemented. And I fully agree with you. I think the governance mechanism probably is one thing which we need to address it a lot more clearly, so that the impact is much better. And also what you mentioned about outcome-based reimbursement, I think that's the direction in which probably many countries have gone, and is something that we need to also take a look at it. There are several questions that I have received, and I'll go through them one by one. One of the first questions, Nachiket, is that what is your assessment on how insurance sector and insurance policies are changing, particularly for addressing the innovative medicines that can be accessed by the Indian patients? Because sometimes these medicines are in rare disease or, cancers, etc. And the therapy also becomes pretty expensive. So what are your views on this?
My understanding, Mr. Ananthakrishnan, is that the insurance regulator, and I have an opportunity to engage with them a little bit, is a very proactive regulator. If you see during COVID-19, for example, they moved quickly to include and mandate the inclusion of COVID-19 contracts in the insurance space. Clearly, and also there were all these onerous clauses and complex designs which allowed insurers to not cover a particular pre-existing condition or perpetually keep somebody out of the coverage level. Many of these things have become clearer, have become sharper, so that consumers are not being denied access to insurance unfairly. The way I see it, Mr. Ananthakrishnan, is clearly working with the regulator, talking to them about diseases, ensuring that there is a sensible conversation with them is the way forward for rare diseases or for other. I think you will find them warm and very receptive to these conversations. The challenge though, and I think this is not a challenge as much with the regulator as with the industry and with the overall healthcare system, is how do we expand access? Because currently the total health insurance expenditure in the country accounts for less than 5% of total expenditure. And I think the biggest impediment to the supply of anti-cancer drugs or to supply of more advanced medicines is not so much that the insurance contract will not cover a particular medicine or a particular treatment. That I'm not saying it's not an issue, it is an issue, but I think that can be dealt with, is that most of us and most of our fellow citizens are uninsured, which means we have to show up with 5 lakh, 10 lakh, 20 lakh rupees in our pockets. And that immediately restricts the market to a much narrower. Whereas if universal insurance was there, many more families can afford the 10,000 rupees a year or 20,000 rupees a year, which allows them access, if there is a cancer disease, to 5, 10 lakh rupees, 20 lakh rupees of cover. That is the missing puzzle for us, which I think, I'm hoping that we will solve sooner rather than later.
Thanks, Nachiket. The second question that has come is, because you touched on it, and that's the reason I'm taking up this. What has worked well during COVID times with analytics and insights to build the future working model for pharma? Because we did see a lot of changes, particularly using digital tools, digital technology in the last 1.5 years. How do you think that this will pan out in the future, and what are your views on it?
I think, Mr. Krishnan, what has happened, which I think is positive, is that there has been a recognition that technology and technology-based engagement with patients is an important way to engage with patients, is an important channel. I think pre-existing regulation prevented this from happening. And that if you were sitting in a remote area, the medicine was right in front of you at a pharmacy that you could go to, but because a local doctor could not physically see you, you were not able to access that medicine that you need. And this was true of chronic disease, it was true of acute care, it was true of so many issues. I think there has been a recognition that this is no longer the right idea. And indeed, diagnostic tools, diagnostic mechanisms, and that physicians need to be trusted. If they think that based on a telephone consult, they are confident that a patient can be started on a treatment, that trust must be afforded to them. And in the concern on the other side, though, is that has this led to a further fragmentation of a relationship between primary care providers and patients? Because now, as a patient, I no longer need to set up an appointment with my primary care doctor who's 2 blocks away. I can simply call a specialist because I think that this little irritation in my throat is, throat cancer. So I want to talk to an ENT surgeon, right? I feel that's the damaging part of it, that we need to find a way to bring under control. But I think COVID has really allowed us, and I was quite involved in COVID. You mentioned in your opening remarks the work that OPPI did, and what I'm very heartened to hear from you and so many others, so much of private activity, non-government activity supported the government. We were involved as a group through Swast Digital Health in the distribution of 40,000 oxygen concentrators on a nationwide basis. And many of these are today saving lives of newborns, of mothers, of cardiac patients, COPD patients in very remote areas. Again, technology has played a very big role inadvertently. Nobody wanted COVID, but because COVID happened, suddenly there are 200,000, 300,000 facilities that actually have, equipment that they didn't have earlier.
Nachiket, the other question, which is in a way interlinked, is that how do you think digital transformation will enable universal health coverage agenda of the government? Whether this will, accelerate, and what role pharma industry can play to enable and contribute towards universal health coverage?
Sir, pharmaceutical industry has a critical role. You don't need me to say that. You yourself mentioned so many ways in which pharma industry has been playing a role. In India, the unfortunate reality is that on the plus, we make all the medicines that we need. In some cases, we are amongst the world's largest manufacturers. In others, we are importers, but we work with licenses and make them. But a large part of our country is unable to access these medicines. COPD is the number 2, number 3 disease in many states. But how many remote areas can give you even salbutamol? Very few, right? And I'm not even mentioning cancer. I'm not mentioning many of these drugs, right? Clearly, there is a challenge to ensure that using your good offices, your channels become much more enabled. As I mentioned in my remarks, and if you look at the work of the International Federation of Pharmacies, 80 countries permit, directly or indirectly, pharmacies to get directly involved in the provision of chronic disease care. Now, this needs the new, technology enables this to happen. But there is a real opportunity for pharma companies to go there and say, why don't we trial this? Why don't we work with a few of our trusted pharmacies and really see? Because India has a depth of penetration of pharmacies. We have 800,000 pharmacies in India. This can become an important channel through which primary care can be given of a high quality, enabling them, giving them technology, giving them training. A survey I was involved in finds that many pharmacies are now not run by the old grandfather that started it. It's a young generation that has taken over. They don't want to do the same old thing that they were doing earlier. They want to be modern. They want to do new things. I think your constituents could become effective partners of these entities and work with the International Federation of Pharmacies. I know they are desperate to find a foothold in India to work with Indians and work with us and work with Indian pharma companies to deliver more value to the citizens of India.
That's really wonderful and encouraging. I only hope that some policy movement also happens in that direction.
Current disa policy is not such a barrier because of the technology enablement.
Okay.
If you as a pharmaceutical company say, I'm going to deploy a bank of doctors that are going to be my referral partners for the pharmacy and employ a digital platform to do this, there is no fundamental barrier today in technology. Challenge is more training, evidence base, all of that, which I think is very much in the hands of your constituents.
Thanks, Nachiket. The other question that has come is, can you give us an example of any other comparative country, and particularly example China, how China has bridged this missing middle gap? And are there any learning from there which can be replicated in India?
So China, unfortunately for us, in some ways has gone so far ahead that I would not even hold them as a necessary benchmark. But since you asked me what are some of the dimensions, first of all, the government has increased its healthcare expenditure to a level 4 times higher than us. Right? That's a significant jump in contribution towards healthcare, which has meant that every citizen, even a rural resident, is able to access care without necessarily being impoverished. They've also spent a lot more effort than we have on public health. For example, tuberculosis. It claims 300,000 lives in India even now. We just don't talk about it as much as we talk about COVID because the lives lost, sadly, are those of the poor. COVID hit all of us, and therefore we became very concerned and very agitated. China doesn't have this problem. They have found a way to ensure that tuberculosis is dealt with consistently. I think where they have a lot of learning to do is really more in the social determinants, in One Health. Are they thinking about the zoonosis, the animal-human transfers? Are they thinking about design of cities as they build these mega cities? I'm no China expert, but my limited visits to that country suggest to me there is new learning to happen there. Because I worry that a lot of the gains, they have relied on the healthcare system and on medicines, but have really not paid as much attention to the dust storms and to the overcrowding and the pollution levels and all of the live animal trade that is so concerning as far as One Health is concerned.
Thanks. There's one question which has just come, Nachiket, which says that you mentioned price levels will not become a barrier in increasing access. When can we see that change happen in India, and what do we need to do for that?
No, as I said, sir, the real gap is twofold. One is government needs to step up with more money. No country, and sadly, I looked for exceptions, but no country has been able to do good healthcare without government expenditure. And this includes what I would call fiercely market economies, like Japan, like Switzerland. Those of you that are Swiss, and I'm sure many of you here are Swiss, you'll find the whole history of Lamal the act that was passed, and was passed with a narrow majority. I'm told it was 50% plus a few dots, and 49%, 50% and minus a few dots against, that led to the passage of that bill, but that really got the government very involved as a financier. I think we are going to have to engage with this issue much more robustly. There's no shortcut around it. The second issue is we will need to think about the whole issue of bringing providers and insurers much more closely with each other. Because today what's happening is both are on the opposite side of table, and the belief is that there is a conflict of interest. And sadly, like in an R.K. Lakshman cartoon, the patient is watching this from a distance, very anxious, because they're both deciding his future, but he's not at the table. Yeah. Right? Now, this really needs to change. We need to bring these two together and put the patient back at the center of the conversation. Because I think many people could buy insurance. Government could say that you're not confident of commercial insurance. Why don't I? And fortunately, thanks to Dr. Indu Bhushan and so many others, the National Health Authority has built a lot of power. Today, it does lakhs of transactions per day. It works with 40,000 hospitals on a seamless basis. Right? Can we deploy that capacity to launch a government-designed insurance contract using the best principles of managed care? I think we can. Even as we wait for the state governments to find the money. Right? I think these two steps would have to go hand in hand for us to, because I don't want a situation in which if I or a member of my family or a member of my staff goes to a hospital and money becomes a barrier on care. I'm not saying, therefore, medicine should not be reasonably priced. They should be. Right? But I would say currently our problem is not so much reasonably priced medicines, but much more that people just can't pay for them.
It's the other question which has come, Nachiket, it seems to be interlinked to this. What is the scope of innovating impact financing in delivering healthcare outcomes for the government and attracting private capital for public health in India?
I think so. There is a lot of room for these kind of innovations, this kind of experimentation. I certainly hope that many investors will get into it. But unfortunately, health is a large-scale business. We are a large country. Helping 20,000 people is important. I'm not telling you it's not important. It is very important. But we need, if you ask me, who do I want to see at the table? I want to see the big telecom giants, the big retail giants, their CEOs sitting in and saying, I want to build India's next healthcare system. And here is $5 billion that I'm committing to it. Right? That's the money we need, sir, to transform this health system. Not the 20 million and 40 million and 100 million. Those are important. I'm not going to tell you that's not important. Innovation is important. Ideas are important. But that, I don't think that's going to solve where we need to go. To set up a reasonable hospital is $200 million in India. And to set up a health network, even to serve 5 million people, that's going to need at least $1 billion of commitment, right? That's the kind of money that I think needs to be brought to the table.
Thank you so much, Nachiket, for joining us today. I think it has been a very thought-provoking conversation, and I'm sure it is going to lead to many more questions which will come our way, and maybe we will reach out again to you to some clarifications, as we take it forward. But really appreciate your taking the time and joining us today in this program. Over to you, Kathy.
Happy to be here, sir. And my request to all of your members is, if they have good examples, the good ideas from their countries, please share them with me, because we in India need to learn from the whole world. The problem of being a laggard is we're not doing so well. The benefit of being a laggard is that we can learn from everybody that's ahead of us. And I really like to use that opportunity to do that. Thank you very much, sir.
Thank you, sir, so much. Really appreciate it. Kathy, over to you.